Now, good morning, Ms. Stephen.
Good morning, my lord. The first witness this morning is Michelle Morrison.
Good morning, Ms. Morrison.
Good morning.
Right, when you're ready, Mr. Stephen.
I'm obliged. Could you confirm your full name, please?
My name's Michelle Morrison.
Thank you. Your age and contact details are already known to the inquiry, so I won't ask you for those. You've helpfully provided a detailed written statement already to the inquiry, and for the record, that reference is SCI WT 0414 and then 5 zeros and a 1. Are you happy for that statement and the oral evidence you give today to form your evidence to the inquiry?
I am.
And are you happy for that to be recorded and published?
Yes, I am.
Thank you. And everything you've said in your statement will be taken into account even if we don't cover it in oral evidence today.
Okay.
And the last thing to mention before I start asking you some more questions is there is a restriction order in place, so please don't name any specific individuals when you're giving your evidence, whether it's a staff member, family member, whoever it happens to be.
Okay.
Right. I'd like to ask you first about your role in the organisation you're representing today. I understand that you're National Development Director for PAMIS, promoting a more inclusive society.
That's correct, I am, and I've been in that role for the last year or so, and I was a Family Support Service Director with the organisation prior to that.
And how long were you a Family Service Support Director for?
I was in that role for about 18 years before becoming the National Development Director, and 22 years altogether.
Okay. And what is that role as a Family Service Support Director involve?
So there's quite significant levels of support that you give individual families who are caring for people with profound and multiple learning disabilities. That can range depending on the individual family's needs. So we have families who care for people who are very young, right through to people who are older adults. So that covers lots of different ages and stages of needs. So it might be educational support, it might be with social work, it might be through the health sector. It might be about how people access inclusive lives. It might be about housing issues, a whole range of different types of support that families needed, and that was our role within family support.
Is there a typical family that you deal with, or?
No, there's a very large range of families, so despite the fact that we fall under the label of profound and multiple learning disabilities or profound intellectual and multiple disabilities, whichever label you would like to use, actually there's quite a spectrum of people within that. So we have people who may well be wheelchair users, for example, full-time wheelchair users who have very limited function, through to some people who have got a bit more grasp of using maybe 1 or 2 words of language, who may be able to move around and whose function might be a little bit higher. So that also impacts on the type of support that we give each family, because they're very different and diverse.
And I think in terms of the support you offer, you talk about dealing with, I suppose, the serious stuff, but I think you also try and have fun as well. Is that fair to say?
Yeah, there's a really important part of the service is about how we try and not only manage some of the crisis situations that come up for families, but also try and allow people to have a life as well. And one of the big things about our organisation is recognising what inclusive activities actually are, because they are so limited for people in the general community. So it's about how we make storytelling, arts, crafts, being out in speedboats, whatever it is, and try and make families recognise that there are things out there that they can enjoy and have fun doing. So that was a really important part of our job, and allowing families to come together, and the support that can offer as well. That peer support's really integral too.
So I noticed that paragraph 11 of your statement, you talk about all the different age ranges of those that you're dealing with PMLD, to use the shorthand. But I think you also say that you continue to support families even when they lose a person who's they've been caring for with PMLD. Is that right?
Yeah, absolutely. The caring role is so intense for our families. Every minute of every day is devoted to the person that is being cared for. And so when that person dies, there's a huge loss. There's a huge loss of identity in terms of how you fill your day, how you move on, and how you cope with that grief. Because lots of services are specialist, you also lose contact with those specialists as well. So not only does the person die, but all of the connections that you had related to that person disappear as well. So it's really important for us to recognise that loss and how to help families to stay connected and stay connected to people that understand as well. So we will quite often allow those families to join us in various different activities that we're holding. But over the last number of years, we've also tried to hold a memorial service as well once a year, just to allow those families to come together. And again, that support that's there to share that grief and loss as well.
Thank you. I think I heard you say that you've been working for PAMIS for 22 years, is that right?
Yeah, yep.
What was your professional background prior to joining PAMIS? What were you doing before that?
I started off my professional career as an occupational therapy assistant working in a long-stay hospital. So that was working alongside people who had a range of different learning disabilities. And latterly in my time there, it became more focused on people with profound and multiple learning disabilities. We had an increasing number of those people who came to live in the hospital in which I worked because there had been closures of other long-stay hospitals. And from there developed that passion of recognising the joy that people with profound disabilities can bring to life, and had the great fortune to then work in a learning disability service that was very specific to profound disability. It was a day centre that was set up by families who absolutely recognised the lack of resources that were there for people with profound disabilities. So it was very small, very family orientated, allowed me to build on those skills of activity that I had developed within the long-stay hospital and support not just the individual with profound disabilities, but starting to recognise what the issues impacting families as carers were as well. And from there moved to PAMIS. So it just felt like a very natural progression.
Sounds it, yes. I want to turn now to ask about postural care. That's a key theme, I think, that emerges from your written statement. I think at paragraph 18, you say that you're one of the main people within PAMIS working on that subject. I think, as you just said, that perhaps that was a natural fit, given your background in occupational therapy, would you say?
Yeah, absolutely. Working in the long-stay hospital, we were part of, because I worked in the occupational therapy department, we were very closely linked with the other disciplines, so physiotherapists, speech and language therapists and dietetics. And we regularly would come together as a multidisciplinary team, especially for people who had more profound disabilities, and look at some of the issues that were affecting those individuals. When I then moved to work in the day centre, it was in the same local area in which those professionals within the long-stay hospital worked, and as part of their community role, they would work with the people that I worked alongside in the day centre. So my whole working career has been very much around how we support individuals with a profound disability to maximise their functional capacity, and posture and positioning play a really important part of that. So I think when the opportunity came up within PAMIS for us to host a workshop around posture and positioning, it was something that I in particular felt really interested in because of my background, and it was something that just made so much sense. But it's also something that we recognise is not intuitive, so it is something that people need to learn. They're not necessarily just going to understand that we need to protect someone with a disability's posture and positioning. We maybe think a little bit about how we protect our own, but we don't necessarily think about all of the implications that arise for people who have a disability.
Thank you. Yes, I noticed that in your statement at paragraph 17, you mentioned PAMIS holding a first postural care workshop, I think as early as 2010, 2011, with families, and every year thereafter, so a long-held project or passion, you might say.
Yeah, and it started off very much as several areas of the organisation would hold a workshop with specialists who came along to chat to families. But from that, families were then saying, we want to know more about this. So their relationship with physiotherapists and occupational therapists up until that point would be very much the therapist delivered the information or support or intervention to the individual. And families wouldn't necessarily do much at home, but what we were learning through these workshops was actually posture and positioning is about a 24-hour picture. It's not just about the half hour or hour that the physiotherapist is actually in the school or in the day centre. And actually the implications of how we lie has a huge influence on how our body changes and distorts if we have a disability. And that was something that families had never heard before. So they were really keen to do something to change that and help other families to have more information around posture and positioning. So from that, we actually then went on to try and get extra funding because as a third sector organisation, funding is always tight, so you need to apply for funding to do specialist pieces of work. So we were able to successfully get several years' worth of funding to support postural care education and growth within several different areas of PAMIS. And alongside that, families played a really important part in helping to shape what that information looked like and how they could reach other families. So families were really engaged in creating We've got a postural care film. We have information that sits on our website. We've got our education delivery. And a lot of that wouldn't be possible without families' intervention. So it was something that grew in interest across the organisation as well.
Thank you. And we'll come back to that education and funding in a little while. The paragraph 20 of your statement, you highlight postural care as a key issue, a huge issue, I think, is the way you put it, for those with profound and multiple learning disabilities. Why is that risk of postural deterioration so significant for those with PMLD?
When most of us move around, we move in quite symmetrical movement patterns, and that allows our body to function relatively well. Many of us might recognise that if we sit, for example, for a long period of time in one position, or if we use the same chair every day, we will sit in a particular way, and that might create some aches and pains. For somebody with a profound and multiple learning disability who doesn't have any or very much control over their own movement, they are relying on other people to help them move and change those positions in the way that we don't even think about. We just get up and move around. But there are gravitational forces that will distort an individual's body if they don't stand, lie and sit well in those symmetrical positions. And I had the unfortunate, I suppose, position of working in the long stay hospital to see the true distortion that can happen to people when the right supports are not put in place. So, and that wasn't because that anybody was doing the wrong thing, but 30 years ago we didn't understand those biomechanical forces and gravitational forces that we now understand cause those distortions. So somebody who's a profound disability, who isn't able to get up and move around, whose muscles are weaker than ours, are at severe risk to those gravitational and biomechanical forces. And what that then causes to happen is the body to distort quite significantly. But there are pieces of equipment and there are techniques and there's understanding that helps to stop and prevent all of that from happening. And that distortion can lead to quite significant health and well-being implications as well. So if you start to lean over to one side, for example, you're going to compress your lungs. That and will then impact on your ability to breathe and breathe well. So we do have quite a number of people who will use oxygen because of the compression that's been placed on their lungs. Quite often, because the body is distorting, you'll then have a movement of internal organs, which means then that it can be difficult for any surgical intervention to happen. So if you don't, so say your swallow has become compromised because of your positioning, you then can't eat or drink orally, so then you need a tube to do that. But actually it then becomes difficult to know where your stomach is for that tube to be put in place. So there are lots of different implications that are related to the distortion that somebody's body can experience.
Is that distortion potentially fatal if left unchecked?
So there's certainly statistics coming out, or research coming out that have looked at both adults with a learning disability and children and young people with additional support needs that state that the respiratory function is a high determinant of avoidable death. And whilst postural care alone will not necessarily stop that respiratory function issue, what it will do if good postural care is put in place is make it easier for somebody to breathe, make it less likely that somebody will have issues with their swallow, and will prevent a chest infection or pneumonia. And it's the chest infection and pneumonia that are quite often the contributing factors to that respiratory function that causes death. So absolutely it could potentially contribute to be life-sustaining.
And I think you touched on this in one of your answers a moment ago, but outside a pandemic, how would you ordinarily manage or mitigate that risk of postural deterioration in someone with PMLD? What would you require to manage that?
There'd be lots of equipment, lots of knowledge and lots of hands-on support. So in a 24-hour picture, you're talking about every way that you sit, lie, stand and move being monitored by somebody who supports you, whether that's your family carer, whether that's your physiotherapist, your occupational therapist, your teacher, your classroom support, your day service worker, your personal assistant. All of these people will be key to helping make sure that every position that you adopt during the day is maximised to allow you to have best function and most protection from that distortion. And alongside those people and the hands-on knowledge, you need bits of equipment as well. So it might be things like ankle-foot orthotics, which are a splint that helped hold your foot in a certain position. It could be a specialist wheelchair. It could be hand or leg splints that try and minimise some of the contractures. It could be thoracic support that's on your wheelchair, so lots of different types of equipment will support that as well. But you need the knowledge to understand why you need the equipment, if that makes sense.
It does, thank you. And I think at paragraph 30 you make the point, don't you, the wider point that postural care is important not just for those with PMLD, it can apply to other conditions as well.
Yeah, so anybody who has a difficulty with their movement, that is, and the more significant that difficulty with your movement, the more likely you will start to experience some distortion in how your body manages itself if the right supports aren't put in place. So certainly some of the regressive conditions like motor neuron disease, multiple sclerosis, there is a chance that you will start to develop some distortion related to the lessening ability to move around. If you live with cerebral palsy, you will be at risk, and again, the more affected you are by your cerebral palsy, the more at risk you are to your body distorting. And historically, that has been thought of as being an inevitability that your body will change. But I think increasingly interventions that have been provided primarily by physiotherapists and occupational therapists are highlighting the fact that actually we can do something to slow down that regression. So learning disability are quite far ahead in the field, if you like, compared to some other organisations understanding the issues that are related to that postural distortion. And that's why the postural care strategy that was created in Scotland was such an important document, because it helped take what we were learning within learning disability and look at other people who were at risk, and like older people. The more you are reduced to sitting and lying as well, the more of an impact that distortion potentially has on your body as well. So the creation of that strategy was recognising that this was wider than just learning disability and profound disability.
Thank you. We'll come back to that strategy in a second. Paragraph 6 of your statement, you say that in 2020 you yourself were in, I think, a transitional stage, is the way you put it, moving away from directly supporting families. You'd obviously been a family service support director previously, to focus more on protecting the body shape of those with PMLD. And why that change at that time?
I think it was just a fortuitous time where we had been building up the knowledge and resources we'd been creating within the organisation. We were in a real push and momentum. Our families were behind us. We had very good support from a number of families across the organisation who wanted to drive change across the country. So what we were potentially seeing were pockets of really good work in some areas, but not consistently across the country. So the funding that we were looking to apply for and were successful with the Alliance, that one day's worth of funding, was to try and reach some of the areas that PAMIS didn't have a family support service, so that we could try and influence the knowledge growth for those families, and also work alongside the allied health professionals in those areas to help create those really positive relationships that support postural care. And alongside that, we had been building up and networking our contacts of interest in postural care across Scotland as well. And so we were starting to connect with allied health professionals and third sector organisations who were also really interested in postural care, and we were all coming together really to try and change how we address that as a country, and try to create some standard and consistency in what people were receiving, regardless of what led to your need for that postural care support. So the work with NHS, the specialist board, it came around because they recognised the benefit in having that consistent support across the country, and so that allowed us to start writing that strategy. So I think it was just a very fortuitous position that was building on the momentum that we had been building across the organisation in relation to postural care.
Thank you. Because yes, at paragraph 7 of your statement, I think you talk about those kind of two strands of funding. I think, as you say, on the one hand, Health and Social Care Alliance in respect of education for families around postural care and moving and handling, which we'll come on to later, and secondly, funding from NHS Education for Scotland to support the writing of this strategy that you mentioned. I want to ask you now about that strategy. You touched on it a little bit already. You say at paragraph 7 that you were the lead author of that postural care strategy for Scotland. Was that as part of a strategy group? And I would ask you, without naming any individuals, where were the members of that group drawn from?
Yeah, that was part of a group. It was the connections that we had been making within PAMIS for the couple of years preceding us coming together as a strategy group. And that had people who represented allied health professionals in particular across a number of different territorial boards in Scotland, primarily physiotherapists and occupational therapists who were sitting on that. And they covered a range of services, so children and young people services, neurological development, learning disability. We also had some third sector organisations, and we had family carers. So it was quite a wide breadth of representation that sat on that strategy group. And I think at the time that we were a strategy group before, you know, the strategy itself was launched, there were maybe about 15 to 20 of us that were quite regular attenders to that group.
And you touched on this already to an extent, but what was the catalyst for this strategy being created?
I think the wave of families in PAMIS who were interested was a really dynamic push on changing things. I think that allowed us to have slightly different conversations across some of the territorial boards in which we were working and connecting. Being able to say, you know, families are saying we need to do something different. Families are suggesting that, you know, we need to listen to them so that we can change and grow and do something a little bit differently to how things have been done before. So it was certainly a challenging period of time, I think, in trying to influence, inspire, and persuade people to come together. But I think that was definitely something that helped to drive it forward, was the dogged determination that families within PAMIS had to make a difference. And our responsibility then organisationally to try and make that happen, so to kind of keep pushing at doors and keep asking for people to become involved, and a willingness amongst practitioners to change as well, and be a part of that kind of pioneering approach, I suppose, and how we did something differently, because it was very much a co-produced piece of work, which is something that is quite unusual. Yeah.
And at paragraph 60 of your statement, you say that the writing of that strategy was paused, I think, due to the pandemic. I think you talk about the NHS Education for Scotland having to focus on COVID-19 education. But you were asked instead, was it to write educational resources at that time while that was down tools on that? What were you asked to write about at that time? So
there was a recognition that postural care could potentially support the respiratory function of people who had a movement difficulty, and particularly if they were experiencing symptoms of COVID-19. So thinking about people in care homes, for example, that NHS Education for Scotland had the ability to reach out and get information out to. They were really keen that we were able to create something quite specific that talked about how we could potentially maximise that respiratory function in particular, to help alleviate any of the issues that might come alongside COVID-19. As much as I was saying postural care was something, it's something that's a huge part of our organisation, but we are still, you know, the conversation around it is still very small in Scotland. And so there are lots and lots of people who don't know about it. And I think this was one way that NHS Education for Scotland thought we could really capture some ideas around how we could potentially alleviate some of the suffering potentially that people would experience. And just try and do something that was a bit more proactive. And I think some of the thoughts around how we breathe and how we would best manage if we had a chest infection might be slightly different if you're somebody who has a profound disability, for example. You know, if you ask somebody with a profound disability to sit up and they're not supported, then they will entirely compress their lungs, and therefore their respiratory function will decrease quite significantly, and actually that could be quite detrimental. So even just in some of the language around that information was thinking about, well, actually, is there, you know, what position is this person best in to maximise their oxygen levels, and maybe we need to be monitoring that. So it felt like quite a privileged position to be asked to put that forward on behalf of the strategy group. So that was something that PAMIS led on, but the strategy group very much supported the writing of that at that time.
You go on to say, I think, that the strategy itself was launched in the summer of 2021. Would the Scottish Government have been aware of the formulation of that strategy when it was going on?
Yeah, so Scottish Government were very influential in the whole process of the strategy, from the Chief Allied Health Professional a good number of years ago, back in, I think it was maybe 2017, 2018. It was through their support that the strategy progressed and was able to become a document. So Scottish Government were very much a part of that strategy group and the creation of working together co-productively and listening to those families' voices as part of that whole process. So yeah, they were very heavily involved.
Okay, thank you. And I think in paragraph 62 you talk about the real excitement in writing that document. What was it you hoped to achieve with it being published?
I think we just wanted everybody to know that postural care was really important to the health and well-being of so many people. This document has the ability to help practitioners best support individuals who have a movement difficulty, which can have huge impact on the health and well-being of individuals. You know, I think within our organisation at PAMIS, we're able to see a number of families where either the child or young person is less likely to experience distortion or hip dislocation or some of those issues that would very much have been classically seen in people with profound disabilities. And knowing that there was that potential to influence practitioners to give them a way of working that could include individuals and the people who cared for them in their health care and understanding of postural care. Because I think one of the things that we talked about earlier is that postural care is not intuitive. You need to know what it is in order to help you best understand how to maximise somebody's movement throughout the day. And just knowing that we could potentially capture that through the strategy, it felt like such an influential position to be in, to change the lives of a projected significant amount of people across the country.
And were you also looking perhaps for a consistency of approach
Yes.
across Scotland into how you look at that issue?
Yeah, very much. The document itself is broken down into 3 ambitions, and one of those ambitions is very much around how the person who has a movement difficulty sits right at the heart of any decision around interventions. So it was a very different way of working to maybe how some of these services had been delivered historically.
Thank you. And at paragraph 65 of your statement, I think you expressly mentioned the Scottish Postural Care Forum as maybe a lasting legacy of that strategy, if I can put it that way. What does that forum continue to do on the subject of postural care?
So currently we are trying to oversee the implementation of the 12 or 14 recommendations that sit within that strategy. We have just recently launched 6 modules that sit on NHS Education for Scotland's TURAS platform, and that enables anybody across health and social care to access those modules and build on their knowledge of what postural care is all about. We're currently working with a range of different practitioners across Scotland to look at how measurement is carried out of people particularly people who have a learning disability. Historically, people who are linked to a physiotherapist will be measured to check and monitor any distortion that might be happening with their bodies. But there isn't really a standardised way of doing that. Different services will do that in different ways. So they're currently looking at how they can make that a standardised approach. We are always trying to look at ways that we can increase the voice around the importance of postural care, what it's about, why we would need to be interested in it. And we're currently looking at a postural care awareness day. So there's lots of different things. And I suppose everybody who sits on that forum comes voluntarily. There's no extra, there's no cover in your post, backfill cover, if you like, to come. So everybody who comes volunteers to do those extra things to help move postural care forward.
And before I move on, the recommendations that you mentioned, are those still to be fulfilled, partly fulfilled? Yeah,
they're still to be fulfilled. There's a number of them that we are probably well on our way to having achieved, but I think it's fair to say that the impact of COVID has slowed down a number of those recommendations being put in place. There were recommendations around equipment, for example, and we know that kind of has stalled quite significantly. There was a recommendation about how we could work better with health and social care partnerships and territorial boards, but they're still in a state of flux, really, since the impact of COVID, and so that has become much more difficult to progress as well. So yeah, there's definitely some of those recommendations that feel a little bit further away than they did when the document was being written.
Thank you. I wanted to move on then to the impact of postural deterioration during the pandemic. Paragraph 82 of your statement, you say that around the end of 2021, I think when some normality at least was coming back, PAMIS started to receive inquiries about, well, posture-related issues and equipment. Who was getting in touch with you and what were the issues that they were raising with at that time?
There were a range of different families getting in touch, from children and young people through adults, from people who were wheelchair users to people who had mobility. So there was a range of different issues cropping up for folk. I think maybe by the time we got to that normality kicking in, families were maybe less in that kind of panicked stage of trying to manage everything that had been going on during lockdown, and maybe starting to look at things in a slightly different way to what they had done previously, because as services were starting to open back up, and what they were starting to see was bits of equipment had maybe been outgrown or needed to be maintained or changed, or had been overused and worn out and were no longer meeting the postural support needs. And so if somebody can't use that alternative bit of equipment, that does have quite a big impact on how else you manage your life. If somebody is a wheelchair user, you pretty much only have the ability to lie or to sit. And so if your wheelchair, for example, is not supporting you as well as it could be, then you don't necessarily have another alternative to get out of the house. So these pieces of equipment can be quite integral to the function of somebody with a profound disability. So we're starting to get inquiries about some of that equipment having failed or needing to be maintained or having been outgrown. But there were also other issues cropping up where, so some people maybe who had been mobile, gaining weight, because they weren't moving around as much, they weren't at the services and activities that they had been previously. That gaining weight then meant that it was more difficult for them to walk around the way they would have been able to previously. And if they were able to, I'm thinking of one young man in particular who was able to move around, but he needed physical support to do that. He was then putting lots of extra weight onto his carer to be supported to walk around. So that had quite significant impact on his postural deterioration as well because of his leg positioning. There's also several families reported having issues with tightening of muscles. And I think, if we all sat for quite, long periods of time and maybe we didn't exercise and we tried to touch our toes, we'd probably feel that quite tight down the back of our legs. And we don't necessarily see any of those changes physically when we look at ourselves. But quite often when we look at people with profound disabilities, that muscle tightening happens quite quickly and is really noticeable when, for example, the person comes out of their wheelchair and lies either on their bed or on the floor because they're not able to stretch their legs out. So when you then try to stretch that leg, so say you're helping the person get dressed, that can be quite painful and cause a lot of discomfort. And if that tightening remains and isn't stretched, then that's when you're starting to lead down that path of distortion as well.
And when you were receiving these queries to PAMIS, were your family support service directors able to do anything about the issues that they were being told about?
It was becoming quite difficult to navigate the systems of support that had been there previously. Even where some services were coming back to normal, there were slightly different routes and processes that had to go down. You had to go down to be able to contact people. So I think it's probably fair to say that family support found it difficult to navigate where to get support from professionals that maybe would have been involved previously. What they were able to do was to direct families either to myself or other colleagues who may be able to speak individually to families and talk about some movement activities that could be done to help alleviate some of that. Or for me, for example, I might have had slightly different contacts with physios or been able to try and make ways forward in a way that family support service directors might not have had the same contacts. So there was lots of conversation around us amongst how we tried to get the best information to families to allow them to deal with what was happening. And I think, unfortunately, it's also fair to say that what happens with that deterioration is a huge level of guilt for families as well, because they then start to blame themselves for that deterioration happening. And I think especially at that time when there were no other interventions, there were no other people coming in to support, families were having to try and manage lots of different things that were going on. And so there was a lot of guilt around some of that distortion. And that in itself can then make it, or not necessarily distortion, but tightening. And that in itself can make it difficult for you to look for help because you feel that it's your fault that that's happened.
Thank you. In paragraph 81, you mentioned the redeployment of physiotherapists and occupational therapists. Did you receive feedback about the impact, if any, that was having on those with PMLD?
Yeah, it was a really difficult period of time for families. So I think they kind of felt abandoned. That the usual person that they would pick up the phone to wasn't there. I think things happened so quickly that lots of those physios and occupational therapists that families would have had connection with didn't have time to say, this is where I now am, or here is where to connect me, or here is who you can get in touch with because I'm not here. None of that was put in place. So it was really difficult for families to start to make some of those connections and contacts. But what physios and OTs were trying really hard to do, the people who were left, because I think in some departments there was like one person left to kind of man the department. So they were trying really hard to let folk know that they were there if they could offer support. But that in itself was limited as well in what they were actually able to do. Sometimes they weren't working from their usual bases. So I think social media played a part in trying to create some of that support for families, but it was really difficult to get. It was really difficult to get tailored and individual information for families.
Thank you. In your view, should these issues, postural deterioration issues, for those with PMLD or indeed others, have been foreseen by the Scottish Government as a result of the restrictions that were put in place as a result of COVID?
I would love to say yes, it should have been. It should have been. I mean, certainly it's something that our organisation have been talking about for a long time. It's something that is known across lots of AHPs, again, physios and OTs in particular, because things like school holidays, there are always deteriorations that we see during a school holiday time, whether that's a long summer break or whether that's a fortnight at Christmas, when people are out of their usual routines of types of support that they receive in day centres or schools. Then you start to see deterioration. So I would love to say that they should have been aware of that, but whether there are just so many other conflicting things going on, or things that seem to have a higher priority, and maybe postural care just hasn't quite captured the importance that it should have.
Because yes, at paragraph 105 of your statement, I think you say, I do not think that I could say that the importance of postural care would be understood if there was another lockdown tomorrow. Why do you hold that view?
I think even though it's something that as an organisation we are incredibly passionate about, we acknowledge that everybody that our organisation supports is at risk of their body shape deteriorating, and that we have a number of carers who wholeheartedly agree with us. We still haven't got that message out to all of the families that we support, and we still do see some of those distortions and deteriorations happening even where families do know and understand. So I think even within our organisation, we know that it's an important message, but we haven't reached everybody. And even though I know that I'm involved heavily in the strategic work that's happening across the country, sometimes I think those practitioners that are involved in that feel a bit like a lone voice within their departments and their teams and their organisations. And so I think it's just, even though we know it's really important, I think it's not recognised. I think everybody really needs to go through that educational process to understand why posture changes and the impact that has on an individual, to truly then start to recognise the importance of postural care. And if you don't go through that process, I think it's really difficult for people to grasp. but it fundamentally underlies almost every other issue that an individual, certainly an individual with profound disabilities, will experience, whether it's a respiratory function, whether it's the function of their arms or their legs or their head control or the way that they eat and drink. All of that fundamentally is supported by good posture and positioning, but it's really difficult to get that message across to people.
Perhaps that's why you're here today, or at least one of the reasons why you're here today. You say it's very important, and you've presented a very persuasive case why it is, presumably because you want us to think that it is. Well, and that's
Yes.
not a criticism at all, and possibly make recommendations. Is that fair to say?
Yes, it definitely is.
Yeah. Understood.
Thanks.
Obliged. Because, yes, I mean, if there was a lesson to be learned then, and we are obviously, as an inquiry, interested in what recommendations can be made, you mentioned education. What would you suggest is the lesson or lessons to be learned here if postural care wasn't sufficiently taken into account during the pandemic? What would you suggest?
I think education is such a huge part of how we can make change in relation to how people understand postural care. We have a huge health and social care workforce, and lots of those people will come into contact with somebody who's a profound disability. And if you start to understand how best to manage some of that, then you will see a difference in the way that somebody is supported in the treatment or intervention or care that you're trying to carry out. And some of that will be made so much easier and so much better if you understand postural care. You know, sadly, we see situations where people have been in a hospital situation, and the team around the individual, you know, a couple of emergency situations, the team around the individual have not understood the importance of posture. Families have tried really hard to convey the message, and we've had experiences where people have nearly died because posture and position has not been carried out in those emergency situations, because those practitioners are desperately trying to save that person's life, but they don't understand the implication of posture and position in relation to their profound disability, and that's something that we need to change. We need people to understand that posture and position is integral to so many people that we care for, not just people with profound disabilities, but so many people that we care for. And I think that's something that that sits underneath all of this, is how do we better educate our health and social care workforce.
Thank you. Before I move on, I was struck at paragraph 91 of your statement. You say that the damage done by COVID and the restrictions in terms of postural care can partly be measured, and I think in terms of data is what you're getting at there. Could you please explain what you mean by that when you talk about how that might be measured looking back as to the impact that postural care had? Because you've talked about families feeding back to PAMIS, but this seems to be about data. So what are you referring to there?
Within children and young people's services, they have a measuring system that's called the Cerebral Palsy Integrated Pathway System, or CPIPS, and that sits across Scotland. And the physiotherapists who are working with children and young people who have cerebral palsy, or I think more recently who present as though they have cerebral palsy, will be measured to look at something called a hip migration. So for children and young people who don't weight bear, so a lot of those people are people who have profound disabilities, their hip joint will not form the way ours does, because we get up, we move around, and that's what creates our ball and socket joint. For people who don't have the ability to get up and move around, they will have a very flat socket, so it's very easy for their hip to what's called migrate and dislocate out of that joint. And that's something that has been a big issue in profound disability for a very long time. This measuring system is something that keeps an eye through X-ray on children and young people every 6 months and looks at the position of that child or young person's hip. And so it then flags up at a potentially early stage to say there is an issue and we don't want it to worsen enough to get to the need for surgical intervention. But what we do need to do is make sure that the wheelchair is correct, they've got a lying system for bed or various other bits of equipment that might mitigate the issue of the hip dislocating. So that is a system that's been in place for, I think we're maybe about 5 or 6 years that system has been in place. So it will have good pre-COVID data, but it will also start to produce data that happened over the last, or didn't happen over the last couple of years because clinics weren't taking place, those x-rays weren't happening, so there will be a gap in time between pre-COVID measurements and post-COVID measurements, and so that data might well start to show whether there have been changes or not during that period of time. Now that data in itself is limited because it is only very specific children and young people who would be measured under it, and it is only that the hip location that is being measured, but it will give an idea of what has been happening for some people during that period of time. Some therapists, physios in particular, do measure other parts of the body, and there are some territorial boards who are already looking at chest measurements, because that's something else that will distort and change shape as other forces come into play for people with profound disabilities. So some physiotherapists are already capturing that, but again, it's not consistent across the country, and that's why the forum is currently looking at trying to get a standardised assessment across the country, so that everybody's looking at the same type of data, and that way we can then get a good picture of what's actually been happening. But there will be some pockets of data that will allow us to see the reality of what distortion has happened during that period of time, but certainly anecdotally, from physios and OTs as well as from families, we know that there have been deteriorations for individuals.
Thank you. I want to move on now to the impact on family carers themselves. We've obviously talked about those being cared for, but I want to focus now on carers. At paragraph 32 of your statement, you say that so many people do not understand what our family carers go through on a daily basis. And again, at paragraph 53, you say that if you don't understand the complexity in caring for someone with profound disabilities, you absolutely do not register, and I paraphrase here, how physically demanding all of that is. Are you able to give the inquiry a flavour of what those demands are, even in ordinary times prior to the pandemic, that are placed upon the families that you deal with?
For lots of people with profound disabilities, they are entirely relying on a caregiver to manage every aspect of their life. And so from the minute you wake up in the morning, you are potentially unable to alert anybody else to the fact that you're awake and that you want to get up out of bed. So families need to be aware of what's happening, and quite often they will sleep with baby monitors during the night to hear any vocalisation that might be happening, any seizure activity, any disturbance that's happening during the night, but also to alert them to the fact that, that the person has woken up in the morning. Then what will often need to happen is that that individual will need to be hoisted up out of their bed or physically moved from their bed to an alternative position. So that will quite often be a wheelchair that the person will be transferred into. So in order to make that transfer, you need to put on a sling, you need to mobilise a hoist, you then need to attach the sling to the hoist, make that transfer, lower the person down into their wheelchair, and then you can move around the house. Depending on what's actually happening in the morning, you might also want that person to get dressed at that point, and you might want them to go for a wash at that point. If you want that person to go for a wash, you will probably undress the person on the bed. Depending on the hoisting system that you have, you may have a single track that's in your bedroom, which means you can be hoisted up out of your bed and into a wheelchair and then wheeled to your bathroom, where you then have to make another transfer to get into your bath. Or you may have a mobile hoist that allows you to make that transfer from bed to bath. And you also need to be physically undressed to make that, to get ready for the bath. But then you also need to be towelled and redressed once you come out of that bath. Most people who have a profound disability will also wear incontinence pads, and that's something that needs to be changed several times a day, depending on other issues that are related for the individual, whether it might be medication that they're on, or seizure activity or digestive function. They may need that pad to be changed 7, 8 more times a day. And that in itself is really physically demanding, because you're then having to partially undress somebody. They are generally lying down at this point, but you'll have to partially undress somebody. You then need the person to be able to stretch their legs wide apart so that you can change that pad. So that can be, depending on how tight somebody is, that can be quite difficult just to manage that movement. You can obviously then change the pad. When it comes to eating and drinking, the majority of people will need to have something done to their diet in order to be able to manage it. So it might well be a blended diet or a mashed diet or a specifically prepared diet. So not only have you then had to make the breakfast or the lunch or the dinner, but you then also have to prepare it well for the individual. Sometimes you need to add something to it, so you might need to add a thickener, or you might need to add an additive that allows it to have more calorie content, because lots of people with profound disabilities are underweight. If you are supporting somebody who can eat or drink orally and they eat and drink through a tube, you then have to go through a particular process of flushing out the tube, preparing syringes, giving that feed. And I've only touched on getting dressed, having a wash and having something to eat and drink. So the demands that are placed on somebody who cares for somebody with profound disability are really quite significant. It can take half an hour to do one transfer. It can take half an hour to get somebody dressed or undressed. It can take over an hour for somebody to actually eat. So these are quite intensive caring tasks. And a previous study that had been carried out suggesting that somebody who cares for somebody with a profound disability spends between 8 and 10 hours delivering just personal care tasks, like eating, drinking, getting dressed. So yeah, it's really quite intensive to care for somebody.
And if it's that intensive during the ordinary course of events, what were you hearing and seeing from families as regards the impact of the pandemic on caring for those with those needs?
Exhaustion and overwhelm. It was an incredibly difficult time for families. Lots of people would be supported, whether it be by school staff, day centre staff, home care workers coming in, personal assistants. There would be, at some point of the day, somebody would be coming in to give you a hand to some extent. So that varied from family to family, and could be, quite substantial support to minimal support. But I would probably say all of our families had some level of external support that came in to help. So what you were then having is potentially that 8-hour gap in the day where somebody would be at school or be at a day service or be supported elsewhere, that you were then picking up all of the care that was required during that time as well. So there were all of those additional moves, transfers, positioning, changing, pad changing, meals that you weren't needing to do generally. So families were exhausted, absolutely exhausted. And I think what carried people through initially was, this is 12 weeks. It's 12 weeks, just let's get to the end of 12 weeks, we can do this. And then fatigue starts to set in, because it becomes not knowing when it's going to end, and how do you keep going when you don't know when it's going to end. And so lots of our families would have not only the help that comes in a daily basis or a week-to-week basis, but they would also have respite as well. So that tended to be something that was overnight, and it might have been for more than one overnight at a time. And that was the kind of break that allowed our families to switch off and recharge, and that opportunity wasn't there. So there was a real desperation and exhaustion and overwhelm. It was really significant. And when you're thinking, we've talked about the physical demands, but even that moving and handling somebody, the amount of times you need to bend and adjust and twiddle with attachments and various different things that are parts of equipment or wheelchairs or whatever else, it's hugely physically demanding.
Are there any specific examples that you were getting from families about the physical impact upon them? For example, in paragraph 33, you talk about the musculoskeletal impact, I think, on carers. Were there any specific physical, I hesitate to use the words injuries, but at least impacts you were finding on those caring for those with PMLD? Yeah,
back and shoulder pain were two very common complaints that families had. And, with the best will in the world, we would be trying really hard to encourage families to use equipment where they had it, to try and lessen that burden. But even the demands of using that equipment, we could be talking about 8, 9, 10 transfers in a day. So even though you are using the correct equipment, it's still really physically demanding. Moving somebody to put on a sling, adjusting somebody once they're in their wheelchair, repeatedly throughout a day, regardless, these are really difficult manoeuvres. We have had a couple of families where they have already had deterioration, one in a hip joint, one in a knee joint, that was exacerbated during the pandemic because of the amount of physical movement that they were undertaking.
And do you think the complexity of those demands, those daily demands, was understood by the Scottish Government in imposing these restrictions?
I don't think so. I think there was a recognition that carers needed support, and I think the carers policy team at Scottish Government absolutely understood that there were significant needs for carers, and they were trying really hard to get information out around vaccines and various other things that were happening. But I think, like I mentioned earlier, in terms of the spectrum of learning disability and profound disability and just how diverse even the profound disability community is, the caring community is diverse, and people are carers even with relatively small tasks that they carry out. And so I don't think the intensity is necessarily recognised of somebody who's a profound disability, or how potentially long and ongoing that is, because quite often you're caring for your child. So many families will have been caring for a very long period of time, and I don't think there's any of that recognition that actually you've been caring for your son or daughter for the last 30 years, you are getting older yourself, you are feeling a little bit more tired generally. I don't think there was necessarily any recognition that that was any different to anybody else who falls under the remit of being an unpaid carer. So I don't think that was recognised. I think carers were recognised, but not our family carers as having a more intensive caring role.
But presumably you think it should be better understood?
Yes, absolutely.
Thank you. I wanted to move on now then just to the work of PAMIS during the pandemic. You've obviously to help those facing the burdens that you've spoken about earlier today. The inquiry's heard a lot of evidence previously from various organisations about the pivot required from physical working to online, and I don't think PAMIS is any exception to that. In paragraph 35, you talk about the change from the delivery of in-person training to online training and having to upskill, I think is the word you use, family carers. What was involved in that task of upskilling, and how straightforward or onerous was that task?
It was broken down into two different groups. We had family carers who were trainers, and we had family carers who were delegates or participants of that education, and both needed different sets of skills to be able to either attend or to deliver the education. The 4 family carers and the physiotherapists who were involved in delivering the education, they needed to change all of their materials, and they were not able to do that themselves. So they would have previously gone out, delivered in-person training, maybe with a PowerPoint that somebody else had set up, excuse me, on a laptop, and flip chart paper, and that's what they would have used. And as an organisation, we needed to get all of that up online onto a Zoom platform. And we had to change and record lots of material, so recording over, like voiceovers of presentations, recording families and the individual stories that they were telling, helping, it kind of seems odd now going back to that point, but helping those who were presenting understand how to mute and unmute themselves, how to share the screen, and how to, I suppose, just that, something that you don't get when you're delivering online, that you get lots of feedback when you're in a room, and you don't get that when you're delivering online, and just trying to manage that for those carers that were involved, because so much of it is those side conversations, or just that general feeling of warmth or acceptance that's happening when you're sharing your stories. And one mum in particular talks about her son who died, directly related to the deterioration in his posture, and for her delivering that online was quite difficult. So there was lots of different ways we had to try and support those families that were involved in delivering the education. But even the families who came along as well, how to click on the link, where does that take them? The fact that they might be in a waiting lobby, what did that mean? Once they actually came into the Zoom room, what could they touch or not touch? depending on what they were logging in with, had an impact on how they actually came up on screen as well. So, for example, we had a family who logged in on a tablet and they were touching the screen, but what they were doing was actually drawing on everybody else's screen. All of those things that we now probably can't imagine doing now. So there was lots of work that we needed to do in two different ways. But lots of our families also didn't have a means to connect to that education either. So they either didn't have Wi-Fi or they didn't have a device. So other colleagues had been working with Connecting Scotland to try and fill that gap, so that we were trying to, because we were mindful that in delivering digitally we were excluding people, so trying to be really mindful about how we tried to make it as equitable as possible for people to come along and join us.
I was going to ask about digital exclusion and if that was a concern, but
Yeah.
I think you've answered it. Do you think that gap was filled then, if that was a concern
Yeah,
to
I mean,
reach those families?
I think the Family Support Service directors not only were able to get devices and dongles that delivered Wi-Fi for folk, but also were able to support people in their learning of how to use these devices as well. So that was a huge role that they took on too. Because if you're taking something like a tablet to somebody who's never used one before, and you know, I think it always surprised me at how, for want of a better expression, tech savvy, I think that's the way I've written it in the statement as well. Some of our families actually were, and so these felt like really strange devices for a lot of folk. So there was quite a lot of work that the Family Support Service directors were doing to try and build up families' expertise in using these. And as an organisation, we delivered lots of different things digitally, and we had lots of engagement from families, and including lots of those families who received equipment through Connecting Scotland.
Thank you. Just at paragraph 37 of your statement, I saw you talk about the utilisation of social media platforms like Facebook to communicate those messages to families. And I was struck because you said you were editing, or one was editing, those 30-minute videos down into digestible small chunks. And it's interesting, I think, because you talked about how demanding the role of carers can be and the hours spent doing that. Was there a balance for PAMIS to strike between trying to help those families but also not overwhelming them at a time which I think you said earlier was a very difficult one?
Yeah, and I think I've already touched on the guilt that families can feel, so there was definitely a fine balance for us. Something that our families have very clearly told us in the past is, please give us all the information, and then it's up to us to decide how we use that information. So we were really mindful that we wanted to make sure that we had all the information out there, but that it was shared in a way that we tried not to put pressure on families to say, you absolutely must do this, but to highlight these are things that you might see changing, and this is what you might want to do if you see that happening, and if you're really concerned, you know, try to get in touch with A, B or C. So there was very much a fine balance of trying to make sure that the appropriate information and support was there, but also to recognise that families might be, well, families were struggling. We knew that families were struggling just to meet the day-to-day needs of the person that they were caring for, without us then putting any additional pressure on them to fill that gap that services were no longer able to fill. And I think it's probably also fair to say that the Family Support Service directors were ready to manage some of that overwhelming guilt that families were experiencing and sharing as well, in recognition that our anticipation that that's what would happen. So it was that bit about how we tried to work organisationally to say, this is what we're going to do, but this is what it might create. So let's be ready for that.
Thank you. And I think you talk about the running of online education sessions in your statement, and on postural care, which we've covered today, but also on moving and handling, which you've mentioned in passing, but I wanted to ask you about now. You talk at paragraph 51 of your statement about an emotional link, I think, or barrier to the use of equipment by family carers, which I found very interesting. What do you mean by that when you're talking about that in your statement?
Quite often when somebody with a profound disability is born, and that recognition that there is a disability there, and whether it's at the time of birth or whether it's very close after birth, what can go alongside that is take your child home and love them, because they might not survive for very long. And so there is a want and desire to comfort and to hold. And at every milestone that child reaches, whilst it's a celebration that they are here and that they're alive, there is also a change in equipment that comes alongside that as well that reinforces the fact that your child is different and your child has differing needs. And that becomes really difficult for families to accept, you know, that move from a buggy to a wheelchair, that recognition that you can no longer physically lift and carry, but that you now need a piece of equipment to do that for you. And so it's very difficult to break some of those habits and connections, because the equipment is, the equipment's a reminder, but it's a barrier to that contact as well. So that is something that can be really difficult for our families to overcome, and start to embrace something that they potentially know will make a difference to their own health and well-being, but there are so many other things that they need to work through in order to get to that point.
Thank you. And finally, at paragraphs 56 and 57 of your statement, you highlight that there were perhaps also some upsides to the running of these education sessions online, albeit they were a substitute to how you would have done things previously. Could you elaborate on what those were?
I think one of the things that we realised was that families actually enjoyed connecting with each other across area. So when we were delivering things in person, they would have been specific to Glasgow or Lanarkshire or Tayside or whichever area we were holding them in. And so families would only ever really know people that lived in those areas. And for the first time, we were holding various different sessions, and so people across wherever. I'm going to say in Scotland, but we had people in Wales and Ireland joining us as well, in some of the postural care sessions that we were delivering. And so that was really good for families to start connecting with people in different geographical areas. It was actually something that we probably hadn't necessarily appreciated organisationally, around the benefit of hearing how things work in different areas, things that might be better or could be changed, or how parents could potentially influence some of what was happening. But also just the connection that we could have with families who weren't, so like in the Western Isles, we had a family who came from the Western Isles and logged in. We were able to deliver education to Shetland, to places that we would not have been able to reach before the days of recognising the benefit of a Zoom platform. So that definitely opened up opportunities for us. And now, even though lots of things are back in person, there are still quite a few things that we run digitally as well, because families have really enjoyed that aspect of connecting with other people, or the opportunities that didn't exist for folk because of their geographic location previously.
Thank you. I don't have anything else to ask you, really, so was there anything that you think we perhaps haven't covered, or could be a lesson learned, or any reflection that we haven't addressed that you'd like to say now?
I think probably the value of people with profound disabilities. I think they have not been recognised at all during this whole process as individuals, as the joy that they can bring. And I think very quickly people have placed judgments on the quality of their life. And that's something that our families have had to fight for a really long time, but drove a huge amount of fear during COVID. So I think that real recognition and value of who individuals with profound disabilities are, but also just that, to go alongside that, how fabulous our family carers are in having come through this whole process. And even though services are still not the way they were previously, are still that love for the person that they care for is driving them to keep going. And you know, just to celebrate that even though things have been incredibly difficult, to celebrate the achievement and the strength that they've been able to show so many others of us through that process.
Thank you very much.
Yes, thank you, Ms Morrison. Very grateful. 11:15.
Thank you, my lord.
Now, good morning again.
Morning, my lord. The next witness is Wendy Scott-Crawford, who's appearing remotely.
Yes, good morning, Ms. Scott-Crawford.
Good morning.
You can hear me all right?
I can, thank you.
And probably more importantly, you can hear Mr. Stephen, I take it.
Yes.
Good, thank you. On you go, Mr. Stephen.
Obliged, my lord. Could you confirm your full name, please?
It's Wendy Scott-Crawford.
Your age and contact details are known to the inquiry, so I won't ask you for those. You provided a written statement already, and for the record, the inquiry reference number for that is SCI-WT0114-5 zeros and a 1. Are you happy for that written statement and the oral evidence you give today to constitute your evidence to the inquiry?
Yes.
And are you happy for that evidence to be recorded and published?
Yes.
Thank you. And everything you've said in that written statement will be taken into account even if we don't touch on it in your oral evidence today.
Yes.
And just a reminder, there is a restriction order in place, so please do not name any individuals, and that includes your daughter and,
Yes.
and other family members, all right? Thank you.
Yeah.
So you're here today to give evidence to the inquiry about one of your daughters. Could I start by asking, how old is your daughter?
She's 21.
And prior to your daughter being born, I understand that you worked full-time, but you gave that up to be a full-time carer for your daughter.
I did, yes.
Thank you. Now, your daughter has a condition called normal pressure hydrocephalus, is that right?
Yes.
And what is that in high-level terms?
It's enlarged ventricles within the brain. It's also known as a ventriculomedia. It's where normally children or young people are given a shunt, but in the womb brain mass didn't develop, so she just had like 2 big balloons in the centre of her brain.
And when did that condition come to light?
Pre-birth.
And what was the prognosis you were given when your daughter was born?
Either she wouldn't survive the birth, or she would maybe just live to about 2 years old.
And what have been your daughter's care needs as a result of that condition?
Quite intensive. Is non-verbal. She has learning difficulties. She's got limited mobility. She's doubly incontinent. She has epilepsy. She's anaphylactic. She has several other allergies which are not anaphylactic but obviously need to be taken into account. So her care is 24/7 care. She can never be left alone, and she needs somebody to help her have a life.
And is that what you enable her to do? You provide that 24-hour care that you're talking about?
I do, yes.
And you said it's 24 hours. What is your daughter's sleep pattern like, for example?
We did an EEG because she's up and down all night, and they wanted to do an EEG for her epilepsy, and it turned out they discovered that she sleeps solid for 1 hour when she's put to bed, and then she cat naps the rest of the night for a maximum of like 15 minutes. So
sorry, I'm going to have to stop you there. I'm being told there was a breach earlier on. Thank you.
All right.
Good, all okay. Right. I'm sorry about the delay, but these little mistakes happen. They don't need to be worried about. Hope it didn't disrupt you too much. On you go, Mr. Stephen.
Thank you, my lord. I think I was just asking you in relation to the 24/7 care that you provide for your daughter. I was asking, I think, about her sleep pattern.
Yes, there was a test done. She's basically up and down all night. She sleeps for 1 hour solid when put to bed, and then she cat naps for 15 minutes. Part of her condition, I forgot to mention she's autistic, is that she doesn't like the covers squint. So she'll get very distressed, very agitated, and you could be up several times a night, either changing her, obviously she's incontinent, making sure her covers are straight, or, well, it's just several times a night. So you're up and down all night, basically.
And given your daughter's range of needs and what you've described as the routine through the night, what impact or pressure does that place on you as her carer?
It's become the norm. Life is quite foggy. You're tired all the time. You just go through life. Like I say, foggy is the best way to describe it. You don't. You just, your whole life is just making sure that her needs are met. And sometimes, if you've had a particularly bad night, you have to pick and choose what's going to take priority and what isn't going to take priority through the day. Your world becomes very small. It's just living tired.
Thank you. And I asked you earlier about your daughter's care needs. How would you describe your daughter's mobility, physical mobility? How is that?
She has very limited mobility. She has what they call right hemiplegia, which is a right-sided weakness. When she has seizures, it's very similar to somebody that's had a stroke. So you have to go back and do hand over hand, help her with her feeding. She's back into her wheelchair. She requires a lot of physio to get back out of the wheelchair. A lot of the support, it's like 3 steps forward, 2 steps back with her care. She's also got a visual impairment, which impacts when you have got her up, then she can't see obstacles, tables, curbs. Just think she would fall over them and injure herself quite badly.
This is what you talk about at paragraph 19 of your statement about your daughter having no, I think it's 3D vision or depth perception. Is that right?
Yeah. Yes, it's quite common with hydrocephalus.
Okay. And how does your daughter communicate? You said earlier that your daughter was non-verbal.
Yes.
So how does she communicate?
Pointing, gestures, facial expressions. She's very expressionable. We've been using a form of sign language called Makaton, which is a basic sign language. She uses pictures, music sometimes. So if she's wanting to get something across or talk about somebody, she will find a particular song with a verse in it, which took me a long time to work out that's what she was actually doing. So she gets a point across, but you have to know her to know exactly what she's wanting. You have to be able to read her facial expressions more than anything.
And as her mother, you of course understand the signs. You can do that.
Yes, just take a look at her and I know what's coming.
Thank you. I wanted to ask you about your daughter's personality, certainly before the pandemic to start with. How would you describe her?
I would describe her as very sociable, very happy, very giggly, very. She was a joy to be around. She was kept busy at her school, and she loved it. She loved going to school. She loved being around the other staff. She loved her peers. Bubbly and happy is just a really good way to describe how she was before.
Were there any particular activities or interests that she held? I think I heard you mention music earlier on. Was that one or anything else?
She loves music. She loves drumming. She loves art. She's got. She used to have access to a trike, like a special needs trike, trampolining. Again, that was provided when she was at school. She just enjoyed. She enjoyed how she perceived things.
Thank you.
You know, the drawing and the art was a big thing as well. But music is a huge thing in her life.
You mentioned school, and I was going to turn to that, how that was before the pandemic and your daughter's education. How often did your daughter attend school before the pandemic?
She used to go 5 days a week with transport. They'd pick her up and take her to school and then bring her home again.
And what were the activities, the routine that was offered when she was attending school?
It was a very strict routine. Obviously, she likes routine. They had, like I said, the trampolining, they had the art, they had drumming classes, they have a hydrotherapy pool, they have a cinema room. They used to have theatre groups coming in and doing little shows for them. They'd have the bagpipe group coming in and playing for them. They had her walking around the building quite a lot, which was really good for her. They had her out on a trike, they had a physio, they had a speech and language therapist. She used to come home quite exhausted.
Yes, because I saw in, I think, paragraph 28 of your statement, you referred to all the professionals being, I think, under one roof was the way that you put it. So she was receiving speech and language therapy, physiotherapy, occupation. That was all there in one place.
Yes, all under the school roof. They all worked together as a team for that, for each individual. They made a care plan, a package. They were able to get to know my daughter and the others, and they were able to do a programme for them that suited each individual child.
Because I noticed at paragraph 22 of your statement, when you talk about the school, you talk about your daughter being there with full allied healthcare input. What was that input? Is that what we're talking about, the rest of those professionals that were there to support her?
Yes, yeah, the whole allied team all work within the school, so they're all employed by the school, so that, you know, when these children are doing physiotherapy or they're doing speech and language, it's made in a way that, you know, the allied health team would come in and say, right, this is the programme that we need for this individual, this is what we need them to do, this is what we need them to achieve, and this is how we're going to do it. And they would oversee it, but the actual, like, the staff of the classroom would actually physically do what was on the programme. But like I say, they were all under one roof, so it was easy to just phone the school and say, look, I've got an issue with this, or I think I need help with this, what are we doing with this and what are we doing with that? And they made it fun. You know, it wasn't just like going to the gym or some people like that, but it's, you know, the trampolining, for instance, and out on the trike, that's all part of physiotherapy, and that was overseen by the professional physiotherapist within the school.
So I think the words you use in your statement, isn't it? I think you said it was like an extended family. It was more than just a school. Would that be? Yeah. Was that right?
Definitely. Your life becomes quite isolated anyway before, not to its extreme as it has been, but your life becomes all about making sure that my daughter and the others are given a good quality of life. And part of that is, you know, the school's there for a support. And it's the first port of call that you go for anything, you know, any issues, because they're the professionals, you know, the speech and language. It's, you go to them and you ask them about this, or you go to the physiotherapist and you ask them about that. And they do become such a big part of your life. It's not like just dropping your child off at school and going in on parents' evening. It's across the whole board of every need of your child.
And you said earlier in your evidence, and you say it again at paragraph 26 of your statement, about how happy your daughter was at that school. And I think you also say that it was beneficial for you to enable you to spend, you know, time, I suppose, respite perhaps, and time with your other children also. Yes,
definitely. It's you know, when you're at home, it's like you can't even nip to the, you know, like most people, if you're at home, you can nip to a shop, you forgot something at the shop, or just nip back out and get it, or I'll go and do this. With someone like my daughter who's very rigid, you can't do that. You can't just, like, once you're home and you're in, that's it. So if you want to do something, it's a lot of careful planning. It's very difficult to go to a lot of places, particularly with our allergies, so it gave me an opportunity to do that. I had the opportunity to maybe meet up with a friend that I hadn't seen for a long time. I was given the opportunity to spend some time with my grandchild, which I don't get a lot of, and yeah, it just gives you that sort of bit of breathing space.
Thank you. That takes us then, I suppose, to lockdown. By contrast, perhaps. At paragraph 62 of your statement, you say that during lockdown, children got to do online education, but the SEN, by which I think you mean special educational needs, kids didn't get anything. There was no interaction at all. For your daughter, they dropped off art supplies by the house once.
Yeah.
Which begs a few questions. Was there a plan regarding your daughter's educational needs communicated to you when schools were closed?
There was no plan. There was a discussion of how dangerous COVID could be, and that there was a discussion that it was similar to the flu. Obviously, with having an immune system that is compromised, I understood why the school had to close, but I was quite shocked that we were just left to get on with it, really, and to find out information through the local news. I just felt we were just forgotten. We were just, it was really difficult. She just become lost, and I'm not quite sure of the words I'm looking for, but there was just nothing. We could go and look at YouTube videos, and we could pretend we were doing schoolwork, and I could try and write up a plan of what I was going to be doing. Again, I'm not professional, I'm just a mum, and I'm a tired mum, but I'm trying, I was trying to still give her a sense of normality, which again is very difficult when you've got somebody that's so used to such a rigid day and thrives on that, you know, and then when you take that away, it's just, it has such a profound impact. But there was no plan that I could to speak of.
So there was nothing was offered to you or your daughter in terms of how her education would be catered for when lockdown was in place?
No, we were supposed to be going through transition at that time, and obviously we were expecting transition meetings, what was going to happen with my daughter next, where she was going to be going, what was the future going to look like for her, but obviously none of that happened.
Yes, and we'll come to that.
Yeah.
You've used that word forgotten. The obvious question, I suppose, is why? Why do you think? Why this perhaps differential between children on the one hand and other children like your daughter on the other? Why do you think they were forgotten about?
I think a couple of reasons. I mean, obviously, I don't know for sure, and I'm just speculating, really. I feel it's because it's very difficult for them to communicate via computers, or they're non-verbal, they're very limited sign-in. It's very difficult for, you know, it's not like they can go online and do classes, or it was a very difficult, I think it was just, they just didn't know how to reach out to them, maybe.
So you mentioned YouTube, for example, having to look for videos and things. I mean, what was the reality then of your daughter's educational experience when the school closed at home? I mean, what did her week look like?
We spent a lot of time looking at people singing, and people that had put on videos of educational songs, playing the guitar, playing the drums. Singing Hands has been an absolute lifesaver at a lot of things. They're a duo that sing while signing Makaton to songs, pop songs, regular pop songs. She enjoyed them, which again helped with the signing. We watched a lot of how to draw things, and I would sit with her and we would pretend that we're drawing and that they're talking directly to her, herself, even though, you know, I knew they weren't. But it was to try and keep the world open as much as I could.
Could I interrupt for a second, Mr. Stephen? I'm sorry. I want to go back to the answer you gave before, the last answer, Ms. Scott-Crawford. You said, and you were careful to start out by saying that you didn't really know and you were speculating to some extent, and that's entirely understood, no criticism at all. But at the end of that answer, you said, and I quote you, they didn't know how to reach out.
Yes.
And I see that. But whilst I accept that this must be speculation as well, but I'm inviting you to speculate, why didn't they try? Did they make any attempt, for example, to seek out the thoughts of you or people like you, carers like you, so that they might begin to form a plan that might be any use?
I can't answer for them.
True.
But I don't know why they didn't try. I don't know whether it was because of my daughter's age and she was meant to be transitioning into adult services. Maybe it was an awkward age, or because I don't know what happened with the other children. But my experience was there was nothing. There was just the school was closed, and that was the end of it. Just get on with it.
Well, that's very, very candid. Thank you. Thank you very much. Sorry to interrupt,
Sorry.
Mr. Stephen.
Obliged. Paragraph 62 of your statement, you mentioned PAMIS, promoting a more inclusive society. Did you find that organisation, was that during lockdown when looking for support for your daughter?
Yeah, I would go online and try and find resources, and I was getting quite stressed because I felt that her health and mental health and her physical health and everything was in decline. So I would start trying to find different resources to, for support for me, but also support for my daughter. And that's where I found them.
And was that because you didn't feel that you were getting the support you needed from the school?
Well, it was because I hadn't heard from anybody, and I wasn't quite sure where to turn, to be honest. I knew that what her needs were, but who do you go to when if nobody's in the office? Who do you phone? Who do you contact?
And what help, if any, were PAMIS able to offer you?
They managed to get a laptop to us so that we could, for my daughter, and she was able to interact with they put on a virtual disco, they put on a virtual sort of singing group, interactive stories that she would log into, similar to this really, but they were able to say her name and actually communicate back and forth to her. And so we had a couple of them a week.
I suppose in terms of lessons learned, then I'd like to ask you, do you think that the Scottish Government in implementing a decision such as lockdown and therefore to close schools has happened, do you think they gave sufficient consideration to the learning needs of children like your daughter?
No. I think a lot of resources, I can understand how difficult it was and it was unprecedented times and things, but I just felt that as a carer to somebody with such profound needs, we were just left. There was, the other kids got to do online homework, they got to do online activities and things like that. There was nothing put in place for children like my daughter.
And what more do you think could and should have been done? What would you have expected to have happened?
Even interactive videos, even downloading things or like locally from the school onto YouTube, if that's how you're going to access it, so that the children could see the people that have been such a huge part of their life, which just disappeared out of their life. Maybe video messages, video phone calls, group calls, just keep them in the loop, just keep them, they're still part of this, they're still part of something. They're not just shut in their houses and shut in their bedrooms and shut away from everything they've ever known. It's a big ask for somebody, especially somebody that's autistic, to take all that away and have nothing, to have to go and hunt and look for strangers to teach you, or a parent that's not a teacher, that's trying to be a teacher and trying to be a carer, and up day and night, and just stumbling. It's like you're stumbling in the dark.
Did you encounter any other families through PAMIS or otherwise that were experiencing the same as you, i.e. perhaps that gap in education for the children with similar needs?
It's very difficult to actually make contact with other parents, if you like, because you don't get the time to go and to talk. You're so busy in your caring role that I don't get downtime. I can't go and have a coffee with somebody and have a chat and find out what's going on in their life. It just doesn't work like that.
Thank you. You mentioned that word transition a few times. I want to move on to that now, the stage that your daughter was at that time. What age was your daughter when the pandemic arrived?
Should be 17, 18, 17.
And therefore at the final stages of school?
Yes.
Paragraph 28 of your statement, you say that there was an option, I think, for your daughter to stay at that school where you said she was very happy until her 26th birthday. Is that right?
That was my understanding at the time. They were like, you know, we can have children here till they're 26th. And I presumed it was part of the school because it's in the school building. It comes under the same name as the school. And I was quite happy for that. And I just thought things would stay the same right up until she was 26, and it would give us more time to decide my daughter's long-term future.
So that's the option that you would have chosen?
Yes.
Paragraph 29, you say that Allied Health were meant to have completed reports and sent these to the new adult service run by the NHS. Just so I'm clear, what was the purpose of these reports being prepared? What were they there to do?
Well, I didn't know this at the time when obviously I chose for my daughter to go back to Stanmore. I thought all her Allied Health would still be under the same roof because she's still within that building. This is learned after that the reports go because the Allied Health within the school only do children's allied health care, and although my daughter is now classed as an adult, it had to go to adult services and adult allied health care, which is done by the NHS.
And what was the function of these reports?
The reports, were so that there would be a streamline in her care, and everything that the school had wrote in the reports would go to the adult services, and then they would just take over and they would do their input and they would do their reports, and then they would report to the day service and myself, and it was like to be a continuation of her care.
So those reports would enable that transition to happen?
Yes.
And when were those reports supposed to have been submitted, filed?
Just as COVID hit.
And I understand from your statement those reports were not filed. When did you find out that they had not been filed?
This makes me sound terrible. 2 years later.
And were you given an explanation as to why that was?
No, not really. Basically, I had phoned up because my daughter needed some extra physio. I was very concerned about her right side, and when it took a little while to find a phone number for the contact for them, and I knew it was adult services. I'd phoned through to physiotherapy, and they kept saying, can't find her. And I was like, well, what do you mean you can't find her? She should went seamlessly from Stanmore straight through to adult services. And she said, well, actually, she's not open to us. We don't have her here. We've no record of her.
And do you attribute that lack of record keeping to COVID?
I do. I went back to the school and asked them, did you submit these reports? Their services saying that she's not there. They were adamant they had sent the reports. And when I spoke to another member of staff, they said the only thing we can say is that she's probably been at the bottom of the pile and there's been referrals since, and she's just been lost.
Paragraph 40 of your statement, you then say in, I think, 2021, you requested that your daughter redo a year at school, I think having effectively lost a year. What was the response you received to the request that you made for that?
No, she can't have it.
And were you given an explanation for that?
They wouldn't fund it. The education wouldn't fund it, her to repeat a year. She's 18 and it was time to move on.
I see. So what then was the impact? Well, sorry, I'll start again. So in paragraph 33 of your statement, you say it should have been a seamless process. You said that in evidence again, whereby your daughter finished school at 18 and went on to adult support, but those records then went missing. What has been the impact upon your daughter of those records going missing in terms of the support that she was then able to receive?
Well, she's had no speech and language therapist, so she was basically told to go back on the waiting list for everything. So it's took another year for actually the professionals to get involved in her care. So that's like 4 years now before we've got anybody on board. She's had no voice for 4 years. She's just recently been loaned a communication aid to see how she copes with it. She's doing great with it, but she should have had that 4 years ago. She's had no physiotherapy. I've had to go to a private physio because she had an accident and she couldn't walk all last summer. I couldn't get them, she was on the waiting list, so I had to find help elsewhere. She has had no OT. We've had to go on the waiting list for orthotics, splints. We're still waiting on the new one. She's had her legs scanned. Everything's just, she's had nothing but me. And I can't provide a lot of things without the help of a disability social worker or a team. I need a team. A team needs to be around the child or the young person that she is now. And without that team, you can't get the supports and the equipment and the services that she needs. So it's had a profound effect on her.
You mentioned waiting lists. I mean, how long are the waiting lists that you're talking about to receive the equipment or whatever it is that she needs?
Well, it took another 12 months, so it's took 4 years. She got it a couple of weeks ago, and that's been since. She should have got it when she was 18.
And you spoke earlier about phoning physiotherapy. I think you say in your statement that your daughter had a right-sided weakness that you wanted to address, and there was no record of her at all. How old was she been at that time?
She would have been 20.
Okay. And when you were told there was no record, what was it suggested would happen? I mean, you mentioned waiting lists, but in terms of that transition to adult care, what happened?
She was to go back on the waiting list.
To be transitioned to adult care?
Yes.
And were you informed as to how long that would be, or?
I wasn't. They just said she would have to go back on the waiting lists.
And how did that make you feel?
Upset. I was upset. I was upset for my daughter. I felt that she'd been let down. I was quite angry. I was trying to explain, look, she needs input now. I had thought because she'd gone back to a day service that like I say, she was getting that support, but obviously she wasn't. And it was their duty of care to provide that support. And it was like just hitting your head off the wall. So that's essentially why I went to a private physiotherapist.
Yes, because at paragraph 30, you talk about these reports being lost in the system and you being left with no help for, I think, 2 years is what you say there. And you were very concerned about her physical appearance.
Yeah.
Has there been a longer term physical impact upon your daughter as a result of this lack of support?
I would say so. She's very weak down the right side. There's a drop in the shoulder you can see. There's her legs rotated out. She's had a lot more accidents. She's had a lot more falls. She's not steady on her feet as she was. She's actually gained a bit of weight because she can't walk. So she's back in her chair. It's like a catch-22. You can't get her up doing her exercises because she can't stand. She's in pain. She ripped a couple of ligaments in her leg and her foot last summer with falls. So yeah, it's had a profound effect on her.
And was your expectation, if the transition had gone smoothly, that your daughter would have been in full-time education or care again? The
hope would have been that she would have stayed within Stanmore, but 5 days a week, the same sort of hours, but you know, they change it from 9:30 to 3:30 because there's slightly different times of taking them in. But the hope had been that she would still be doing a very rigid programme that she was doing while she was in school, the same level of support and care for her.
And by contrast, I think you say at paragraph 35, for example, that I think 18 hours a week is the figure that you give as the day service that was on offer. That seems, at least at first blush, to be quite a difference. I mean, what was the impact of that upon you when you're expecting something that was 5 days a week and it's 18 hours that's being offered?
Yes, my understanding was that when these young people become adults, that you're not, as a parent, you're not expected to put in the same level of care, and that you could actually go and get a job, or you can, you know, the young person is an adult now, and they shouldn't be spending so much time with a parent. Had a normal, I hate to use the word normal, but has somebody that didn't need that level of care at 18 to 21, you know, you don't spend all your time with your parent. And this, I was always, like I said, I was always told that you won't be expected to do the same level of care. You'll have carers coming in, or they'll go to a day service, or you'll get this, and it's simply not true. You do twice as much care. You know, she's home 4 days a week. I've got to find things for her to do. I've got to be up through the night. I've got to get her out the door. I've got to get her washed and dressed, and I've got to get her to any activities that she's going to. So, you know, and then you're doing the evenings, and you're doing the mornings, and you're doing the 4 days, full days. So there is, what other option have you got?
And you remain waiting for a place on this waiting list, is that right?
No, that's not correct. She has, the waiting list was for the allied health care. They have now started coming in. That's been another year. They've started to come in. That's hence she's got a loan of the voice box. She is doing the 18 hours, which they class as 3 days at this day service. And we have had a meeting recently, as last week, just with a social worker, and basically it was, what's the dream, was the question that was asked. And I was like, well, the dream is that she has her 5 days. I would like a weekend a month off. And basically was told, well, that's not how it works. So I have to wait on another assessment now of my need to find out if my daughter can get these extra days in the day service, or a carer.
Touched on the physical impact on your daughter and also on her education. I wanted to ask you now just on the mental health side of things. Now, I appreciate, as you told us earlier, your daughter is non-verbal, but have you observed any changes to your daughter's behaviour as a result of lockdown and the pandemic?
Yes. This has been a huge change in her personality. She's very frustrated, she's very angry, she's physically violent at times. She's violent to herself, she's self-harming, she's pulling clumps of hair out. It's very distressful to actually watch how she's become.
And what do you attribute those changes to, if anything?
Firstly, the change in routine. Her world has got even smaller than it was before. She's not got the same sort of activities or to do. She's shut in quite a lot still. It's difficult to find activities to get her to, and then obviously again it's picking and choosing your battles. How are you going to fight to get her out? She doesn't like going out the house. She doesn't like walking through the door. She doesn't like getting in and out the car. All things that she enjoyed doing before, she just doesn't want to do anymore. And you have to, I don't want to use the word force. You know, when I say force, I mean as in you have to sort of encourage is a better word. You have to try and encourage her to get out the door. It's like she's developed this fear of the outside world. Once she's there, she enjoys it. She's quite happy to be there, but it's getting her there to certain events. She doesn't, she pulls her hair out, she hits her head. These are all new things that she's done since COVID that she didn't do before. She was happy before, now she's like an angry young lady.
Because at paragraph 45 of your statement, you also mention, I think, your daughter being offered an antipsychotic medicine. Is that correct?
Yes. Yes.
And was that because of the behaviour that you're describing?
Yes. Yes, she'd injured a couple of staff members, and then so she was sent to see a psychiatrist who advised that they could put her on an antipsychotic, which apparently calms them down and basically sorts the aggressive behaviour.
And is that a route that you chose to go down or not?
No. No. I think because she's got so many other medical conditions, you know, she's epileptic and all the rest of it, she takes enough medication, and I was not happy to pump her full of drugs from a problem that she didn't have pre-pandemic. I feel there's got to be a better way.
And so if you were to sum up your daughter's personality now, and I think you did to an extent a moment ago, post-pandemic, how would you describe her now?
I would describe her as an angry young lady, an upset young lady, and a frustrated young lady.
In terms of lessons learned then, paragraph 72 of your statement, you talk about your daughter, those like your daughter, transitioning, moving during the, from child to adult during the pandemic as a forgotten generation, I think is the way you put it. And at paragraph 73, you say that people like your daughter turning 18 at the start of the pandemic seem to fall into a black hole.
Yes.
Why do you think that happened?
I think it happened because services all closed, so there was no streamline from child services into adult services. And what happened was then you had the following year, the next lot of young people were transitioned, paperwork on top of theirs. The next year you had another lot of paperwork on top of that. So the ones that 3 years back were just left, forgotten at the pile. You know, these professionals are getting this workload in, and obviously they're going to start from the top of the pile, and the ones at the bottom of the pile are just left.
And do you consider there to be any key lesson or lessons that should be learned from what happened in respect of your daughter?
Maybe keep services open, even if it's online. Don't close things, or allow them to repeat a year in education so that they can have a smoother transition when all the services are back open. I think those are the two big key issues.
All right. I didn't have anything else to ask you, so if there's anything I've missed or you'd like to elaborate on now, or the Chair may have a question, but now is the time.
Well, I think we've pretty much covered everything. Just thank you for allowing me to speak.
No, thank you, Miss Scott-Crawford, for that very powerful and helpful evidence. I'm very grateful to you. Thank you.
Thank you very much.
Good. Now, we are ahead of schedule, Mr. Stephen. I don't know what the situation with the incoming... I know that you're doing the incoming witness, so we'll put the responsibility on you. If we were able to start at 1 o'clock, I'm happy to do so, but obviously I can't promise that. It depends on availability of witnesses and so forth.
Check now.
Thank you very much.
Thank you.
Good.